Thank you for the opportunity to talk about my research today. I'm going to talk about my master's bioresearch dissertation. My research is about investigating the dose-response association between antibiotic use and the risk of Bullous pemphigoid. It's a UK population-based case control study. To give a bit of background, Bullous pemphigoid, or BP, is the most common autoimmune blistering skin disease. It begins with a prodromal phase with nonspecific symptoms including pruritus, erythema, and urticarial lesions. It progresses over weeks to years to the bullous phase with tense blisters. BP is typically diagnosed between 75 to 80 years, with the highest prevalence in the 8th to 9th decades of life. It has a multifactorial pathogenesis rooted in an underlying autoimmune mechanism. Both disease-related and drug-induced factors have been associated with BP risk, including antibiotics, which have been identified as a potential risk factor for BP, according to Swiderski et al. This study was conducted by our team previously. Notably, in the UK, antibiotic prescribing patterns reflect high exposure in older adults, with 35% of all prescriptions issued to individuals aged 65 years and older, and the highest prescribing rates observed among those aged 86 years and above. So in terms of clinical significance of BP, incidence of BP is increasing globally, and BP has a marked impact on quality of life and is linked with multiple comorbidities. It is also associated with a mortality rate 3.6 times higher than the age-matched general population. Also, the UK has an aging population, so considering all this together, due to the clinical significance of BP, aging population of the UK, and the fact that a huge proportion of antibiotic prescriptions are issued to this population, we can conclude that investigating the association between antibiotics and development of BP is an important topic. This topic was investigated by our team previously. So in this study, we investigated whether there is a dose-response association between antibiotic use and BP. And the rationale behind it was the Hill's criteria, especially the biological gradient criterion, which indicates if an association is causal, greater exposure should generally lead to a higher incidence of the outcome. And in addition to that, identifying such a relationship would also be clinically important, as it may guide risk minimization and safer prescribing practices in older adults. Well, our study design was a population-based nested case control, and the data was recorded by UK General Practices and contributed to the CPRD RM. Our participants included adults diagnosed with BP between 1998 and 2021, which were matched to up to 5 controls by birth year, sex, and general practice. Our outcome was BP diagnosis identified using validated read codes. In terms of exposure, we just focused on those antibiotics that had been previously linked to an increased risk of BP due to our team's previous research. These antibiotic exposures were classified hierarchically according to the BNF into group, class, subclass, and individual drug substance level. In terms of exposure window, antibiotics prescriptions were ascertained in the 6 to 12 months exposure window before the index date of BP for each individual. This 6 months immediately preceding the index date was excluded to mitigate protopathic bias. And a 6-month exclusion period was applied based on the average diagnostic delay observed for BP. Well, when the prescription data was extracted, it needed to be cleaned and standardized to ensure accurate calculation of exposure measures. In order to clean the data, we processed data using the drug prep algorithm, which enabled us to handle implausible and missing quantities, handle implausible and missing numerical daily doses, calculate duration, handle implausible and missing durations, resolve clashing start dates, resolve overlapping prescriptions, and handle small gaps between prescriptions. So when we got the clean data, we were able to calculate antibiotic exposure metrics. We introduced 4 different exposure metrics to investigate in this study. First one was the number of antibiotic prescriptions. Second one was the cumulative number of defined daily doses, which is a standardized criteria to calculate cumulative dose. It is calculated by dividing daily dose by defined daily dose and multiply it by number of days. Defined daily dose is the assumed average maintenance dose per drug per day for a drug used for its main indication in adults. It's a criteria defined by the WHO, and its advantage of using it in this study is that we could not only calculate cumulative dose at the substance level and compare the cumulative dose of different substances with each other, but also we were able to calculate cumulative dose at the subclass, class, and group level. The third exposure metric was cumulative duration. Unfortunately, there isn't any standardized criteria for the cumulative duration, so we were just able to investigate this exposure metric at the substance level. And the last one was the interval between last antibiotic use and BP onset, or simply drug-free interval. Calculation of these exposure metrics were performed separately at the group, class, subclass, and individual substance levels, except for the cumulative duration, which I've mentioned that we were just able to calculate it at the substance level. Well, by assessing multiple dimensions of antibiotic exposure, this study aimed to capture different aspects of antibiotic prescribing that could influence the risk of developing BP. Well, in terms of confounders and covariates, our cases and controls were matched on age, sex, and general practice. Skin infections were considered as a priori confounders, and potential confounders included stroke, dementia, Parkinson's disease, index of multiple deprivation, and ethnicity. Medications which were previously shown to be associated with BP were considered as covariates, and we adjusted for them. In the statistical analysis part, we developed a model to evaluate exposure outcome associations and test for the linearity. We conducted this using conditional logistic regression with fractional polynomials. According to the results, some of these exposure outcome association didn't follow a linear pattern, so we couldn't further do any statistical analysis using continuous exposure metrics. So we needed to categorize our exposure variables to estimate the odds ratio. And we did that using conditional logistic regression. This categorization was based on clinical judgment and pharmacological rationale. Notably, I should mention that Bonferroni correction was applied for multiple testing in both models. These models were developed for therapeutic group, classes, subclasses, and individual drug substances. Here you can see the table of study population. There were around 11,000 cases and 52,000 controls. It can be seen that the mean age at index dates was 76 for both cases and controls. And it can be seen that the proportion of female cases were higher than male cases. And in terms of ethnicity and index of multiple deprivation, there were not a significant difference between cases and controls. When it comes to neurological comorbidities, it can be seen that the huger proportion of cases had a neurological comorbidity compared to controls. Results indicate that there is a statistically significant association between Bullous pemphigoid risk and all the exposure metrics investigated in this study, including number of prescriptions, cumulative dose and duration, and drug-free interval across almost all antibiotic group, classes, subclasses, and substances, except for clarithromycin and oxytetracycline. And these association mostly follow the linear pattern. But as I've mentioned before in the method section, as some of this association follow the nonlinear pattern and we wanted to be consistent, we decided to categorize the exposure metrics based on clinical relevance. As there are too many results for the categorical analysis, I'm just going to focus on the results of the antibiotic groups and the results obtained for those substances which demonstrated strong and statistically significant association. So for the antibiotics, we can see a clear dose-response association. We can see that as the number of antibiotic prescriptions or cumulative dose increases, the risk of developing BP increases as well. And these associations are statistically significant across all categorical levels. According to the literature, we consider odds ratio over 2 as clinically meaningful and strong. So I highlighted those odds ratios over 2. And it can be seen that just by taking 2 or more number of antibiotic prescriptions, the risk of developing BP becomes significant. And the same thing with the cumulative dose, with just taking over 7 cumulative number of DDDs, the risk of developing BP becomes clinically meaningful. In terms of time interval from last antibiotic prescription, the risk of developing BP decreases as the time since last antibiotic exposure increases. Well, for the flucloxacillin, we can see the same dose response pattern as we've seen with the antibiotic group, but with the stronger odds ratios. We can see that just with taking one number of flucloxacillin prescription, the risk of developing BP increased to around 2.2, and it got increased to around 3.4 with 2 or more number of prescriptions. And there are also, this pattern is also among the cumulative dose and cumulative duration with the highest odds ratios across higher categorical levels. In terms of drug-free interval, we can see the same pattern that we've seen for the antibiotics. As the time since last antibiotic prescription increases, the risk of developing BP decreases. But we can see even when the last exposure was within 10 to 12 months prior to BP diagnosis, the risk of developing BP was around 2, which is clinically important. In terms of trimethoprim, we can generally see the same dose response pattern with strong odds ratios across higher categorical levels of exposure metrics reflecting dose response associations. Well, in the discussion section, first I'm going to focus on the key results. There was a statistically significant association between antibiotic exposure metrics reflecting dose response association, including number of prescription, cumulative dose and duration, and the development of Bullous Pemphigoid at most antibiotic levels, except for clarithromycin and oxytetracycline, which was consistent with Hill's criteria for causation. BP risk exceeded clinical relevance only after a specific exposure threshold of frequency, cumulative dose, and duration were reached for selected antibiotics, including flucloxacillin and trimethoprim. And in terms of dose response trends, BP risk increased with a higher number of antibiotic prescriptions. BP risk increased with higher cumulative dose or duration, often reaching a plateau or declining at higher exposure levels, which suggests a saturation threshold. And BP risk attenuated over time after exposure, which indicates a temporal effect. In terms of strength of this study, we had a comprehensive exposure data. CPRD RM captures every primary care antibiotic prescription with dosage, quantity, duration, and issue date. It's a representative database which reflects the UK general population. Um, well, we had a large study population which provides strong statistical power. We went through a robust data processing using the drug prep algorithm. We adjusted for confounders and covariates, and we investigated multiple exposure metrics. Also, we had a detailed antibiotic classification, which allowed us to conduct analysis across therapeutic group, classes, subclasses, and individual substances. And in terms of limitations, well, there is no confirmation of adherence, so these prescriptions may not have been dispensed or taken as prescribed. Another limitation is confounding by indication. So these underlying infections prompting antibiotic use made them self-linked to BP risk. And the last limitation was having limited power in smaller subgroups. So some classes, subclasses, or substances had fewer exposures. Well, no previous study have investigated the dose-response relationship between antibiotic use and BP development. In terms of clinical implication, identification of exposure thresholds for prescription frequency, cumulative dose, and duration can provide actionable insight for antibiotic stewardship. Another implication is that physicians need to be mindful with prescribing repetitive high-dose or long-duration antibiotic prescriptions, particularly in patients with established BP risk factors, including older adults, female sex, those with neurological comorbidities, and those taking medicines associated with BP risk. In these populations, alternative antibiotics should be considered where clinically appropriate, especially for flucloxacillin and trimethoprim, which showed strong and consistent association across multiple exposure metrics. To give an example, flucloxacillin is the first-line treat option for the diabetic foot infection. However, these patients are at high risk of developing Bullous Pemphigoid because of their underlying disease, and some of these patients are treated with DPP-4 inhibitors, which also increases the risk of developing BP. So when it comes to treating the diabetic foot infection, the additive risk of flucloxacillin should be considered, and if um, um, and if it and it can and alternative antibiotics should be considered if it's appropriate. These are the references, and thank you for giving me the opportunity to talk about my research at today's HDR UK Midland webinar. Here's my contact details, and I'm happy to take any questions.